Welcome to the Computational Medicine Podcast, where we discuss AI and computational tools being deployed in medicine. I'm Alex, a doctor working in London. Today we are talking to Jess Morley, who is a PhD student at the Oxford Internet Institute at Oxford University. Her work focuses on understanding the ethical, philosophical and practical ramifications of the increasing use of technology in healthcare. She was the lead tech advisor for data-driven technology at the UK Department of Health and Social Care. She was also a contributor towards the Goldachre review, which looked at the efficient and safe use of health data for research and analysis, and showed how this can benefit patients and the healthcare sector. And it was originally commissioned by the Secretary of State for Healthcare in February 21, and it was published on gov.uk in April 2022. We discussed her current work, what the key factors are that make a medical AI paper effective, and where healthcare data will be going in the future.
Brilliant. So thanks very much, Jess, for coming on to talk to us today. So I'll do a nice, thorough, detailed introduction of you and your background when I sort of get into the post-production part. But if you could just sort of give us a short summary of, say, your background and how you came to work on the projects that you do currently.
Yeah, of course. So thanks for having me. I'm Jess. I'm a researcher at the University of Oxford. I came to be here in a sort of slightly roundabout way that I think mirrors some of what you were just describing around getting interested in this stuff and then being like, oh my God, I need to go and find out more. So about 10 years ago, I graduated Oxford from the first time and in a degree in geography, which is completely unrelated to what I do. I went into the NHS Richmond CCG as it was transitioning from PCT to CCG, and now we of course gone to ICB, initially to do sort of 6 weeks worth of data analysis, and then I sort of never left. I moved through different iterations of the NHS. I briefly went out into consulting, absolutely hated it, went back into the public sector in around 2017, and I was working for the Department of Health and Social Care, which then became NHSX, initially as just general tech advice, and then I became sort of the specialist on AI, purely because I can write a line of code, like nothing more fancy than that. And I suppose at that point in time, I started to get very concerned that I didn't feel that I knew enough, or in fact, anybody in a policy-making position knew enough to be genuinely governing these technologies. And so I sort of thought, right, well, I'll go and get the knowledge myself. Came back to Oxford initially to do a 2 years part-time master's degree, and then halfway through that year I actually switched and I started working for the university. I got a job with the Bennett Institute for Applied Data Science, which is run by Professor Ben Goldachre, and did that for the last 3 years alongside what then became my PhD. And right now, for the last 6 months of PhD, I'm just PhDing, but all of it is about better use of data in the healthcare system in general.
Fantastic. What were the kind of at what point in your career were was this always something that was kind of on the back burner, or was it more like a sudden sort of was the decision to follow the path that you're currently on a slow process or a fast one?
That's a really interesting question. I think it was slow, but then it became very fast. So I think for the sort of first 5 years, I was just generally interested in tech and anything to do with apps and that kind of stuff. And in particular, I'd been really interested in, as an undergrad, on the rise of social media and the influence of that on the spread of culture and the spread of ideas. And then from 2017, things really accelerated with just the focus on data and AI and analytics in general. And then I think after that point, it became very quick, mostly because I became very obsessed and sort of did nothing else with my life after that point. So then it was fast.
So, could you just tell us a bit about, I think I saw recently that you mentioned that you were involved in policy work. So you could just tell us a little bit more about that?
Yeah, so I've been in policy world for a long time, initially as a policy maker, as a civil servant, and then more recently in the last sort of four-ish years, I guess, as a sort of policy analyst on the outside looking in, doing projects like the Goldachre Review, Better, Broader, Safer, which I sort of was the co-researcher and author on. In terms of what I was doing in policy work when I was still a civil servant, loads of different stuff. So I did policy to do with the NHS app, which everyone has become a lot more familiar with since COVID. Policy to do with the NHS's use of cloud and data offshoring. Policy with regards to the impact of social media on children and young people's mental health, and a whole bunch of different stuff, very broadly in this sort of digital space. And then now I do the same thing, but I just tell the government what I think they should do from the outside rather than from the inside.
Okay, great. And I mean, I've met a few people who have had similar positions to that, where they're domain experts and they give the government advice. What has been your experience so far of the government following the advice that you give? It's fine if you feel that that's a loaded question, you don't have to answer.
No.
Having met people in the AI safety space, you can make a lot of noise and it's not always followed.
Yeah. So I think policymakers are under multiple different constraints that you're not when you're an academic thinker. So it's entirely possible for me to come up with multiple ideas about how I think things should work, and then they might not necessarily be responded to in the exact way I would want them to from the government's perspective, because the government also has responsibilities to other areas of policy that I don't. So, for example, if I'm thinking about health data policy, I don't necessarily also have to think about the economy, whereas the government does. And so sometimes that can lead to slightly funny reactions. But in general, I think there is a receptiveness. So, for example, when we did the Goldachre review, we made like 185 recommendations or something like that across 5 different areas of data policy for the NHS. And by and large, 3 out of the 5 areas were responded to. So things to do with open working, things to do with trusted research environments, and things to do with information governance picked up really big. Things to do with data curation, which I'm sure we'll talk about a bit more later, weren't. But I think that's also a thing to do with prioritization. You will always get some non-response, because as well, obviously I do not necessarily align politically with the current government, and so sometimes you have an ideological differentiation there as well, but I think it's just important to remember that there are different constraints on those two sides of the conversation.
Fantastic. Ever seen Yes Minister in the Thick of It? Those come to mind.
Correct. Exactly that.
Spot on. I think I've seen the thick of it. I've only ever seen clips of Yes Minister. I need to go through it more systematically. So I just want to pick up on the Goldachre review actually. So you mentioned a few sort of domains with recommendations there. You mentioned information governance and a few other sections. Would you mind just giving me a quick summary of, say, what the recommendations were within each of those, what the main recommendations were within each domain, and sort of how they were acted upon?
A quick précis, yes.
Yeah.
So we made recommendations in 5 areas, 2 of which overlap. So I'll do them together. So the 2 that overlap is privacy and security, and then trusted research environments. So those are the bulk, I would say, of the review. And the review's purpose was to sort of tackle this question of how do we simultaneously provide very broad access to data in the scale that we need to in order to enable analytics and innovation and research, while simultaneously protecting patient privacy. And the way that the system has done this for a long time is to work off pseudonymization and dissemination. So I take off people's names and addresses, and then you send out big data sets all over the place. That's wildly unsafe from a privacy perspective, because people are readily re-identifiable from their electronic health record, even if your name and address is not on there. And also it doesn't scale. So we sort of came along and said, stop doing this, move to the default of a trusted research environment, or what NHS England calls a secure data environment. In a sort of nutshell, that means you leave the data where it is and you send the code or analytic code to the data, rather than bringing the data to the researcher and they write their code directly on the data. So it's inherently more privacy preserving. There are other benefits which I can talk about later, but basically it's privacy preserving. The next area we spoke about is open working. So there's a real tendency, as you know, you work in the NHS. The NHS does a really great job of projecting this image of being a single thing, whereas obviously not. It's a brand, effectively, that's highly federated. So you have a bit of a system where, if you are looking at performance metrics, for example, how many people are being treated for diabetes in clinical care, in community care, as opposed to in secondary care, that might be calculated 200 plus different ways across the country, and then you're not necessarily getting a single unifiable sort of comparable answer. And so it would be far better if everybody used the same method, put their code that they use out in the open so that people can reproduce it, and also people can error check it and improve it. That's just one simple example. So we sort of said, hey, maybe stop working in silos in Excel with a click button and instead start adopting some more computational methods for data analytics, whether that be R, Python, Stata, and then share that on platforms like GitHub so that other people can use them. So that's 1, 2, 3. The fourth one is connected to that third one, and that was professionalization of the analytics workforce. So the NHS has a huge and vibrant and really wonderful NHS analytics workforce. There's more than 10,000 analysts across the healthcare community, across the NHS, but they aren't professionalized in the same way that other key parts of the clinical workforce are. So there's not a professional body, there isn't a clear training program. They're counted as clinical and admin staff as opposed to clerical and admin, as opposed to clinical. And that just sort of does a big disservice. So what we say in the review is you should professionalize this workforce in the same way that there is the government statistical service and model it off that, so that there is a NHS analytical service that has set job descriptions, a clear career path, clear standards for working, and ultimately good pay, so that people are recognized for doing the really important work that they do. And then the last one was information governance and ethics. So this is everybody's favorite topic, not, but it is mine, which is really talking about what are the rules and regarding purpose of what the data is used for. So if we've dealt with privacy, then what are you going to do with it? That matters just as much. You can still do super creepy things or harmful or unethical things, even if privacy has been protected. But everybody finds ethics and information governance and patient participation very difficult and very painful, because it's multi-layered and really complex, and also involves loads of different steps that are not very clear. So a couple of recommendations that we make in that area is, one, once you've dealt with the privacy problem by putting everything inside trusted research environments, then you don't need to check for privacy, and you can standardize information governance and focus purely on purpose. So you can make the overall application process streamlined and more simple. Then we say make the process for doing proper patient and public involvement and engagement more standardized and higher quality. Basically, don't just go and ask people to tick a box. Are you happy for me to do this with your data? Yes, no. Try and actually involve people in that conversation. And we set out a whole bunch of principles for what that should look like. And then that sort of leads into the ethics thing. So those are the 5 areas. So we published in April 2022. Then in June 2022, so around about a year ago now, the government responded in part through Data Saves Lives, and that was the Department of Health and Social Care, and that said yes to open working, yes to streamlining information governance, and yes to standardizing the use of trusted research environments, latterly renamed secure data environments. The areas that didn't get touched on so much was data curation, which is the last chapter of the review. And that's really where we say you should treat data curation as a topic and valid thing in and of itself. That didn't really get picked up on, and neither did the professionalizing the NHS analytics workforce, because I think those 2 things were seen as maybe a less of a priority, which we can debate later. But so those 2 things did not get necessarily responded to. No.
Okay, and just looping back to the advice where you sort of have the code run locally and then export the data instead of just exporting unsafely, just electronic medical records with the name and date of birth and address removed. Was that was in the context of when moving data between, say, healthcare providers or within the NHS?
So a little bit of
research context.
Yeah, in a research and analytics context. So not so much for direct care purposes, where you're moving between hospitals or between GPs, but when you're disseminating very large volumes of data from multiple people for research or analytics. Yeah.
Right. Okay. Interesting. Fine. Fine. Lovely. Just on the moving data between healthcare providers, EMIS. Oh my days. Just the best thing in the world. Like having worked in general practice, just in my F2 year. Just wow. What is
Mm.
it? And I mean, we use Cerner in the hospital that I'm working in currently, which is also quite good. But it just the idea that you can like port everything over on EMIS between GP practices is absolutely fantastic. I know that
Mhm.
it's very different to like tens, hundreds of thousands of patients' data, etc. But yeah, just that one thing is pretty good. It'd be lovely if we had a similar kind of thing in, just like an EMIS level availability
Yeah.
of information in secondary care. Yeah,
Yeah.
yeah, cool. Okay, fantastic. So, in a recent post, in a recent
Mm.
article, you pointed out that a number of recent systematic reviews found
Mhm.
that the evidence behind a lot of healthcare AI models was actually relatively poor, and across the board, it could have been of better quality. So, what do you think most urgently needs to be done to improve the quality of these studies?
Yeah, so big question, big answer. I think, first of all, a lot needs to be done in the basic information infrastructure of the NHS. So I think, we need to really think about how these models are going to be developed, deployed, and trained in order to make sure that when it comes to verification, validation, evaluation, which is effectively what I was talking about in that post, that there are the mechanisms in place for actually doing that. So there needs to be available, representative, clean data sets against which you can benchmark and all of these types of things. So there's a very big amount of sort of back-end technical work that I think needs to happen before you even think about getting to the point of evaluating machine learning models. But in terms of two sort of simple steps, I'm saying simple in quote marks because they're not really simple, but for thematics, I suppose. The first one, there needs to be much closer collaboration between the clinical community and the technical community. So at the moment, what tends to happen is a lot of machine learning models are built by people who are outside of the clinical context and the healthcare context. They're techies. They know that health has a lot of data in it, and that it would be very useful to be able to use that data, but they don't necessarily understand the context and the complexities of healthcare. So they don't really get, for example, that a human is not an algorithm. And so for that community, it makes complete sense that if you've developed a high performing or highly accurate model, then you're done. Whereas clinicians will come along and tell you, well, no, because just because you've got a really good positive predictive value, that doesn't necessarily mean that this will work in my clinical practice. So there needs to be far greater collaboration between those two communities and generating crossover skills. So clinicians who have some technical skills and technical people who understand clinical skills and the clinical context. And then you will get people saying, well, hey, healthcare is really highly regulated for a valid reason. We're playing with people, we're not playing with Facebook. So there needs to be a bit of a closer collaboration between that. And then the second point is, which I think, again, we'll talk about more, and I'm going to sound so dull, but it's just better governance. We need regulation in this space. There isn't enough at the moment. The stuff that is available is really unclear and wildly confusing for people who are trying to develop machine learning models. Academic publishers play a role in this. They're not really imposing any standards on these papers at the moment in terms of transparency of reporting or what good looks like. And in general, we need to make the whole pipeline more auditable. And then once you've got those things in place, the regulation, standards imposed by the journals, auditing, then you can start talking about these are the exact steps that need to be taken in order to generate good quality evidence, and then you would have available the infrastructure that makes that possible. If you have those things, then I think we'd get better quality evidence. And we've learned a lot about how to do this in the clinical setting. If you look back at what's been done over the last decade with the All Trials campaign, I think we can take those lessons and apply them to software and not think of AI as being somehow exceptional because it's not a drug.
Yeah, it reminds me of this one of my previous guests, Hugh Harvey, who
Yeah,
had a really interesting career. Yeah, yes, exactly. So just that he kind of worked at Babylon and then randomly was asked to sort of get involved in their EU healthcare devices or medical devices regulation team. and now what runs Hardy and Health. It's just kind of like consulting, but for medical device regulation.
Yeah.
Yeah, just really sort of brings some on the particularly on the governance side of
Mhm.
things and the regulation side of things. Really, really sort of brings that to the forefront. So just there are a couple of things that you mentioned there that I just want
Mm.
to loop back to. So you mentioned, say, those in the technical domain and those in the clinical domain, and sort of increasing collaboration between the two of them. I kind of got two questions on that. Can you
Mm.
think of any good examples where that's kind of been deployed really effectively and it's led to like a really good patient outcome? And then the second question is anything that you think can kind of improve that process at all?
Yeah, so I don't know about the outcome. I can think about where things are working, where there are people
Mm.
who are working well and doing that.
Yeah.
And I'll make my BBC Radio 2 disclaimer. Other companies are available. I think this works well. DeepMind, so Google DeepMind have technical people and clinicians who work
Mm.
together the whole way through, and
Mm.
you can therefore really see that in the results that they get. And then I think you also get it in academic community. So, like the Bennett Institute, where I was working before, that is a team of full stack software developers sat literally alongside clinical academics and alongside epidemiologists and generating crossover skills, and then built this thing called Open Safely, which is the sort of UK's biggest analytics platform for electronic health record data. And again, you then start seeing the generation of models. They're not necessarily AI, but they are big, complex, predictive models that make sense in a healthcare context. And so those are sort of some examples. But I think they're very, very rare, and
Mm.
there needs to be a lot more. There are some narrower cases. So I know, for example, there's a lot that happens inside King's College London. They have a team who do similar things, and so does Imperial University and Imperial's Hospital. But these are niche teams, whereas what I'm talking about is the need for that sort of approach to spread more
Mm.
generally across the ecosystem.
Awesome. And you also mentioned data sets, and so
Mm.
to just to improve the quality of these papers. So data sets was the argument, say, ubiquitizing or almost as in the papers that a lot of these models are being trained on, making the data sets that they use more similar between the
Mhm.
papers.
Mhm.
Was that kind of the argument?
Yeah, generally, I think so. Basically, what tends to happen, I think, a lot at the moment is models get generated based on what data people have access to.
Mm.
So, I can get this data. What model can I make off the data? As
Yeah.
opposed to what model should I make that would be useful
Mm.
for the healthcare system? Where do I go and get the data to make sure that I train that model on a representative data set? So I'm not training it on a population in Oxford and then trying to deploy it in, I don't know, East Asia or even central
Mm.
London,
Yeah.
where those two things are just not going to match really at all. And then you can start getting better quality. So what we happen now is people say, oh, I've got access to this data. I'll make a model. Then I'll test it basically using a subset of that data. And then I'll say, yes, this works. Hooray. And then what you would actually then see is that if you then were to deploy that in a actual NHS environment, the data that the model would be then faced with would be so wildly different from the model that it was trained on that the accuracy would drop off completely. And then you would get harms to patients and harms to patient outcomes. So I think there needs to be a real effort for the NHS to make available sort of benchmarking data sets that are of high quality, that are representative, and that are accessible in a safe way, so that you can train models, but more importantly, validate models against patients that the model will actually be facing. And you've seen some effort happening with that in imaging. So there's the National Chest Imaging Database that's built by the NHS during COVID, and run by a guy called Dom Cushon. That's a really great example of that happening. Them going, right, we're seeing all of these models pop up of algorithms trying to recognize COVID and knock-on conditions in chest x-rays. Let's make a validation data set available so that we can test the models. That type of thing needs to happen for many other different types of NHS data before it's reasonable to impose expectations and standards of what validation looks like.
Time and time and time again when I'm interviewing people in the
Mhm.
sort of computational medicine space, this data set question keeps coming up and coming up, and it's really interesting. So things that, and I almost ask every guest, say
Mm.
what are the best examples of solutions to improving the availability and the quality of medical data sets, and quite often ones that come to mind are, say, the UK Biobank.
Yeah.
That's a good one. And I think that Harvard are spearheading, say, like an open source kind of large medical data set. I think that's another one that quite often comes up. But it definitely high. I mean, obviously, that's, let's say give it 50, 60 years, just extrapolating forwards. One would hope that you get to a point where anyone who in the academic sphere wants to try and get some meaningful questions out of a very, very large nationalized database, which is easy to access, high quality, well labeled, and the ground truths are the ground truths.
Yeah, exactly.
Yeah, I mean that is just going to be one of the best things for medicine, right?
Yeah.
Is that the end? Is that what you guys are kind of hoping for, like a nationalized a nationalized database that is high quality, really good ground truths, and any sort of academic or anyone in the commercial sector can kind of tap into it and kind of draw meaningful, hopefully interesting insights from it?
Yes, obviously with appropriate governance restrictions around how that access is managed. But yes,
Mm,
I think
okay.
for example, well, to give you your point already, you mentioned, oh, I wish we had an EMIS equivalent for hospitals. I think sometimes what happens, and I don't think anybody's done it on purpose, but I think there's a little bit of a myth that NHS data, because it's all owned by the NHS, is like sat in a place which has these beautiful longitudinal records, and they link up everybody's journey from the cradle to the grave, and you can just go out there and play with it, because that's what
I've,
comes across in political
yeah, yeah,
rhetoric,
yeah,
right?
yeah, yeah. I've been paper based in hospitals mostly, pretty much.
Yeah, exactly. So then you go and talk to people who've interacted with the NHS, and they're just like, no, dude, you're so far from the truth.
It's
Um,
such hodgepodge. I cannot
yeah,
emphasize how much of a hodgepodge it is.
so I think we've got to focus on that first. We really need to recognize that the NHS needs to be able to crawl before it can
Mm,
run backwards with its eyes closed on one leg. So we need to focus on getting that real foundational information infrastructure ready
mm, mm.
first. Yeah.
Okay, awesome. And obviously, governance is you need governance airtight in that process. Otherwise, you
Mhm.
can't even take the first step. Okay. I really want to talk more about this kind of like nationalized, well, I mean, UK and or international sort of database, and then the governance that goes into that. So what are the steps between now where we have a large amount of data within the NHS, here, there, and everywhere, to say a nationalized, high quality database which has good governance around it. So I guess what I want. The first question I want to ask is more about, say, the technical steps between here and there. So rather than the governance, I'll ask about the governance in a second. So what sort of needs to be done technically, in terms of structure and data systems, between now, here, and there.
Yeah, so I mean, this is loads of stuff that we talk about in the review, and sort of setting that out in really quite painful level detail. But essentially, we need to focus first on curating the data. So, like I said a bit at the top of this, so when I say curating, I mean generally I sort of mean cleaning, but I mean making sure that it's standardized, making sure that where things are missing, that we know that they're missing values and we put them in. So a really simple example is ethnicity. Ethnicity is quite an important factor to know for many clinical outcomes in modelling. It's missing in about 26% of NHS
Mm,
records. There are really important social reasons for that, but we should be making an effort to try and come up with that. Then there's the fact that SNOMED codes are a bit bonkers. I mean, they're amazing that they exist, but they're hard to code and they're often wrong. So an example that I've given loads of times, that people are probably bored of hearing me give, is that we, for example, found a lot of examples of pregnant 70-year-old men. Now,
mm,
that's probably unlikely that there is a more than one pregnant 70-year-old man, right? Turns out that the SNOMED code for fetus and for dodgy knee is really, really similar. And so busy GPs, busy clinician tap, 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 not really paying much attention to their computer screen, paying far much more attention to the patient, accidentally clicks fetus instead of knee, and then you have pregnant 75-year-old men. So there needs to be a task force almost that goes and looks at the quality issues with NHS data and curates it to make it as accurate as possible so that you can then think of this as being high quality data upon which we can train. As opposed to what happens now is every single research project that's done with data, about 80% of the time is spent purely on making the data usable before you start doing anything. And then only 20% is done with the actual analytics. So that's sort of step one. Then it's thinking about how do I make this data accessible at scale and link it with other data sets in a way that is safe and secure. Now, you can do that by putting everything in one place, yes, but then you've got to make sure that that one place is like, Fort Knox watertight, like in terms of its security. But you can also do it by thinking things through like federation. So that would be where you'll run the same code across multiple different locations. So you might run it across EMIS and you might run it across TPP, for example, in GPs. But you also want to think about how do I make that model work so that I can also link in hospital data, but not necessarily just hospital data. I might also want social care data, which is a whole mess in and of itself, or I might want environmental data. So thinking through that. And then you've got to think about the actual methods that are used to analyze it and test it and then check that it's representative of the population. So you need to sort of think through what would I expect this data set to look like if I was looking at the national census. I would expect X% of this many people to be represented in that data set. Are they? And then try and figure out why there are differences. So, for example, there are lots of patient ghosts in electronic health records. So that's where there's a record, but there's no patient that matches up to them. And that patient might have moved countries. They might have died. Like, we don't know. So start doing that matching exercise as well. So those are sort of the basic steps.
It's not so much for just one patient. Sorry. It's just that you mentioned the patient ghost. It won't just be for one person as well. It won't just be like one person has had one interaction. This one person may well have had 20 interactions with 20 different NHS departments. Just so each one person can produce 20 ghosts. Like God knows how many patient ghosts, unknown encounters there are. That's a challenge. Linking all of that up.
Linking it up, figuring it out, then figuring out who's not in the data. So, for example, people without addresses, without permanent addresses, they might not necessarily appear in electronic health records, but they're still important to be represented if you're modeling something. So you've got to start thinking all of those types of curation and security, and then linkage questions. Those are the technical steps really to getting there.
Okay. So what actually is the data structure of the NHS? Because from the top of my mind, I kind of see the GPs having a good sort of bedrock. So EMIS is so for example, GPs should, in theory, whenever a patient goes from primary care to secondary care and they have a service, whether it's a hospital admission or a surgery or an outpatient appointment, they should get a letter sent from, or they should get some documentation of that sent from the hospital to the GP. So, and I guess EMIS documentation is stored locally within GP surgeries. I might be wrong on that. That's my guess. But so off the top of my mind, having just like worked in the NHS, no one ever actually tells you where this data is stored, how it's stored. I have no idea, which is why I'm asking. So my understanding is that GPs probably have a good amount. The hospitals have a good amount, but it's not linked up to all the other secondary care, etc., or tertiary care. So is that the right sort of structure of the NHS? Or their sort of, I can imagine there are also like massive data centers for like Public Health England and other particular services. But is that like a roughly correct estimation of NHS data, or is there more to it than that?
At a very high level, that's roughly it. So in an ideal world, the GP record, your electronic health record, would be your what you call your single source of truth. So that should have one row per event. So an event is an appointment, a diagnosis, a prescription, etc. That works very well when that event happens in primary care. So I go to my GP, I get new prescription for, I don't know, I'm female in my 30s. I get a new prescription for the contraceptive pill, right? That should appear as a new row in an electronic health record. Now, the problem is that not all care happens inside your primary care. So if I then go and get seen by secondary care in a hospital, then, like you said, that will also generate events. Now, that's probably stored locally in the hospital. And now in the hospital, it's unlikely that all of the stuff that happens to you is even stored in one system. So say, for example, I'm hit by a car. I need to be seen by neurology and cardiology. It's very likely that those two specialties are using separate systems for recording the information inside the hospital. Now, in theory, both of those people should then send a letter to my GP confirming what has happened to me, and that should be entered into an electronic health log. Now, everybody knows GPs doing a fantastic, amazing job, but they are under humongous pressure. So most of the time, that letter will either just be added as free text to your record or scanned in and then added as free text. It might not necessarily appear as a single row in your record. So that starts to cause problems. And then there's multiplications of that complexity. If you're dealt with by anything that might be social care, that's not appearing in your health record at all. But we know that social care and healthcare are intimately connected. And then if you are anything with a sort of long-term condition, there's a very good chance that most of your most detailed information will be stored in what's called a disease registry. So, for example, there's an absolutely fantastic one that's run by the Cystic Fibrosis Trust, and that will have incredibly level detail, but that is run by the Cystic Fibrosis Trust. It's not run by the NHS.
There's another good one for MS.
Yeah, exactly. So then you've got these little pockets all over the place.
Really what you need, and it's just kind of realizing how tricky this all sounds, but integrating all of that into one centralized database where it's one row per event. I mean, discharge letters never, they are never, they summarize a lot in a way that isn't necessarily one row per event. And linking all these up sounds pretty tricky. Okay, so let's talk about governance then. So I guess end game where we sort of bring this all into one nationalized database, which has primary, secondary, tertiary care, nationalized databases all linked up in this perfect data utopia. What are the most important factors of governance in making that happen?
So once you imagining, like you said, we've gone into a hypothetical world, but that's all possible, and it's all in a wonderful, secure,
which is a very technical, tricky challenge on its own, as I'm slowly starting to realize.
I mean, we should also be fair. Like, the reason that the NHS is like that is because it's existed for 75 years, right? So the infrastructure has built up organically over 75 years, and it's a bit like dealing with a 75-year-old patient who's got multi-morbidity problems, right? We're not Estonia, who managed to leapfrog all of this issue. So we should be nice. It's hard and possible and difficult, but imagine we've got to data nirvana. Once we've got there, we've got to think about governance is mostly in terms of who accesses it, for what purpose, how do we know that doing what they said that they would do, how do we test that we tell the public that that's what's happened, and how do we make sure that use case is socially acceptable. And those are very nuanced. My social scientist is showing now, but those are nuanced issues. So, for example, at the moment, what happens is things tend to be very almost binary. So people will make sort of decisions that go public sector good, private sector bad, and make these like almost binary decisions about what ethical probity looks like. Whereas good governance is about putting in place processes that allow repeatable and deep conversations to happen around, okay, yeah, actually, we probably do want to allow some commercial access to NHS data because commercial companies are not necessarily inherently bad. but what restrictions do we want to put on those companies once they've got access to the data? So are we audit logging every single thing that they do? And were patients involved in describing the question that they asked? And how is value going back to the system if they profit off whatever they do with the data? So that's what good governance looks like. It's the sort of the who, the what, the why, and the where that is anything beyond privacy protection.
Awesome. Multifarious, tricky questions, which doesn't sound like anyone's got any concrete answers to yet. But I hope that's what we're working towards. That's what you're working towards. But we as a collective are also all working towards. Awesome. Okay. So I think that the point of who has access and why they get access, I think that's really interesting. What do you think are the best solution or the best answers to regulating that? To regulating who has access and why they get, and on what basis they get access. Do we have things that come to mind, for example, would be I guess I would want to come up with an example of a similar sort of public resource that has that can have academic or commercial institutions getting access to it. I can imagine that there is one in the world somewhere, but I can't think of one currently. But I can imagine one that a similar kind of resource where both domains can get access would be something to kind of roughly parallel. But yeah, I just wanted your thoughts on sort of regulating who has access and why they get access.
Yeah, so there are pockets. You mentioned UK Biobank, and Genomics England would be another one where you have got a mix of different actors accessing the data. For me, in terms of what good governance looks like in that space, is repeatable process. So there's a concept that sometimes talk about that's called procedural regularity. So one of the main issues with the way that this stuff is governed at the moment is that, for example, every single GP in England is a separate data controller. So that practice can make up its own decisions about what it says yes to and what it says no to within the bounds of what it says is allowed in the law. Now, that's slightly insane because it means you've got more than 6,000 different people able to make decisions about what access is and is not allowed. I think we should be streamlining that and instead moving towards, for example, a representative body that has GPs represented on there, secondary care physicians, patients, public members, all of this, who are making access decisions in a streamlined and consistent way, and is following procedural regularity. So we know that process for making the decision of who gets access and how much they might be charged for it or what they're allowed to do is repeatable every single time, as opposed to being wildly ad hoc. So I think that sort of repeatable process is actually far more important than what that process necessarily is. As long as it's representative, there's patients and publics involved in the conversation, and every time I know what I'm getting, and then there's an audit log of how that decision was made, I don't think you necessarily need to make it any more complicated than that. The big issue is when governance happens in a black box. So it's happening in multiple different ways across the whole country with no clarity, and the decisions seem random. Then you're creating a really risky problem from a public trust perspective.
Absolutely. Okay. And what do you think? So you mentioned, say, the social side of things in terms of deciding what makes for appropriate use and what might not, and the public being part of that conversation. So what do you think might be some solutions to that? Are we talking, say, what might I guess things that I was thinking, like maybe when interacting with your GP, then sort of some sort of mandate for everyone sort of when interacting with their GP, clarifying how they're happy to have their data used, or there are some other ideas out there of how to sort of bring in the public to having a say in how their data is used?
So, there are big philosophical debates about the national opt-out, for example, but for a minute we can put those aside. I think when it comes to these more specific conversations, models that work really well are things like citizens' juries or citizens' assemblies. So there have been some really fantastic ones, like One London did a great one a few years ago. There was a really good citizens' jury run during the pandemic about data sharing lessons learned from the pandemic. So this is when you have deliberative discussions with with patients in the public. So you'll get a group of people in a room, you will have a very detailed conversation about what if this, what if that, how about this, have you thought about this, and all angles are discussed, and then you come up with a sort of general statement or consensus around how that particular problem should be solved. That is a good way of involving patients in public, and it should be run by people who are trained and know how to do that well. Bad, quote unquote, patient and public involvement and engagement is when it's run one-off surveys, for example, that just give permission for that one specific project under that one specific conditions, and that don't necessarily involve all of the people that need to be involved. So a really good example of this going wrong in recent times was a project called Spectrum 10K that was supposed to be run by Cambridge University, and this was supposed to be looking at how do we improve the lives of people on the autistic spectrum, and looking at their genetics and also looking at their electronic health records. They had permission and consent to access the data from all of the participants. Then once the project was launched, it then was like, oh, we're looking, for example, to cure autism. And there was massive pushback, very, very rightly, from the autistic community saying, hey, actually, we're not okay with that line of reasoning. So that nuanced conversation had not happened, but the tick boxing exercise of did I ask for consent and did I ask that people are happy for their data to be used for research with regards to autism had happened. So that's really where I mean there's a difference between the two.
True. That's really interesting. I guess with large data set studies, the regulations are just a bit newer and a bit less sort of refined and a bit less granular and high resolution on every single aspect that needs to be included in consent. So I guess my question is, where are we at with improving the standardized, like the Helsinki criteria, for example, is every single study that every single medical academic study that I've read always says, oh, approved by the Helsinki criteria. Where are we at with improving, say, a standardized regulation of approving medical studies that use large amounts of healthcare data? So where are we at with that?
Well, not really anywhere. I think we've made progress in the sense that I think people realize now that at least it has to happen. But to a certain extent, I think that has now been interpreted a bit, like I was just saying, as a tick box exercise. So people now get, oh, if I'm going to access all this data, I should probably talk to some patients, but they don't. There is still no real consensus around how that engagement should happen. And again, I think it's a bit of a skills thing. You know, we shouldn't be expecting epidemiology studies and data scientists to know how to do really good social science research and patient and public involvement and engagement. That this because they're different skills. In terms of reaching consensus and of what good that should look like, I don't think we've made anywhere near enough progress. No.
So that brings to mind a recent tweet or article that I saw Hugh Harvey put out, which was along the lines of the EU's regulation of medical devices can be applied to the use of AI algorithms in medicine. And when you phrase it like that, quite often it just sort of rationalizes a lot of the hype. So who do you blame when, say, an ECG machine breaks, or who do you blame when a pulse oximeter or a surgical device doesn't break? Well, they've got very good regulation to make sure that the standards are exceptionally high and the failure rate is exceptionally low. And I don't actually know a massive amount about, say, litigation or where blame gets passed when those things go wrong. But usually, I mean, just anecdotally in my working, I don't usually see these things not work. As in, it's really rare that, say, an ECG machine doesn't work or a pulse oximeter doesn't work, and usually there are sort of other paraphernalia in the workplace that mean you can sort of work around one particular medical tool not working. So the EU's regulation on that sounded absolutely fantastic to me, and particularly applied to AI models in healthcare. So where is the UK's stance in that, and where are we at in the UK?
Okay, so there's sort of slightly multifaceted question. So in the UK law at the moment, yes, basically our law would match what is in the EU, although we are transitioning away from CE marking to CA marking. And software as a medical device is included within the scope of the medical device regulations in the UK. The thing is that at the moment that is undergoing quite a significant amount of change. So they're redefining what software is to include a broader range of things, actually, which is personally is a good thing, but also to change the way in which you assess different levels of software as a medical device. So in the EU, it's class 1, class 2, class 3. What the UK's proposed legislation, this is all proposed at the moment because the MHRA has it all out for consultation, is to mirror more what is done in the US with software as a medical device, which is first of all to base the classification of the device on risk. So what level of risk does this pose to the patients, which basically depends on the level of decision and autonomy that the machine is making on its own, that the software is making on its own, and the type of intervention. So if it's a diagnosis, is it a recommendation, that type of thing. And then they're also looking at mirroring what the US do, which is pre-market approval and post-market approval. So there is a little bit of, I suppose, trying to streamline the process where the US basically regulates the company, not necessarily always the specific piece of software. So there are some proposals going on there. So the short answer is yes, we have software as a medical device as a concept in UK law. We will do going forward. In fact, it will cover a broader range of things. Exactly what that will look like is currently up for debate and is out for consultation. And people who are interested should engage with the consultation because it's a big and very important area of legislation development.
And where do you sit on the European take or the American take on which regulation is best? Say regulating by company or regulating by specific device?
So I personally believe that the EU legislation is better than the US. And I think we can see that in medical devices full stop. And I think we will see it over the time with software as a medical device as well. The only thing I would say is that the FDA, so that's the US regulatory body, were quicker off the mark. So they had stuff out around software as a medical device way ahead of the EU and the UK. So they have a head start, which is why you will see greater claims in the US of, oh, we are a regulated provider of AI, etc., than there is here, for example.
Okay, awesome. So my next question is a bit about ground truths within medical data. So obviously you want all of your ground truths within medical data to be spot on. And with some data types, it's a bit easier to find ground truths than with others. I think that just off the top of my head, the majority of medical AI that I've seen actually being used has been either, say, structural, like optimizing systems, or in stuff that actually gets used on patients day to day. Imaging is most of what I see. And imaging is usually quite, as in with the data sets for imaging, you've usually got quite good because it's been digitized for quite a while. And with that, you've got quite nice ground truth attached to those. My question is, with what do we do for medical, what do we do to ensure in medical data sets that the ground truths actually are the ground truths? Because sometimes you get a labeled chest x-ray that is incorrect, you get a labeled blood test that is incorrect, or some sort of ground truth that isn't actually the ground truth. Do we have any sort of ways of mitigating those risks within healthcare data sets?
At the moment, no. So almost all of that gets done, like I was saying, at the point of research curation. So when the data is then used for a different purpose beyond clinical care, there will normally be quite a lot of scrutiny that's then going on, and people will recognize those issues, but it's not happening at scale and it's not happening on a national basis. So there are sort of two things. That the most cliched way of sort of saying this is the more the data is used, the closer it will be to being accurate, because more people will see it, more people will spot the problems. But you need to do that in a way that doesn't necessarily cause privacy issues. So I think there are a few steps involved. One, I think we need to be teaching, and I mean this in a non-patronizing way, but teaching clinicians and clinical providers more about how important that data is, and in how many ways it gets used and how many different people have access to it and use it for different purposes. Because clinicians are phenomenally busy and they're incredible at what they do, but I can see how, if I'm in a rush and I'm in a ward and I think that this note is really just an aid memoir, if I ever see this patient again or a different clinician sees the patient again, they know what they've done. Quick, tap, tap, tap. Now that's one headset. If you're then saying, or mindset, if you're then saying, actually, do you know what? If that data is not right, it's going into a national basis, it might help people decide what services are funded, it might impact the development of new drugs, it might lead to the training of a model that predicts heart risk. Like, that's a very different level of responsibility on the quality of the data that you're inputting. So I think that's the start. And then it comes back to making sure there's a task force available for curation, which I was talking about before, so I won't repeat.
Garbage in, garbage out. Yeah. Okay, fine. We're coming up to our time limit, so I'll ask a few of the last couple of questions. Are there any top book recommendations you have?
It depends what you're after, but I was thinking about this a little bit. I think if you are just looking for a general introduction to AI stuff, then you really can't go that wrong with Eric Topol's Deep Medicine. It's a great introduction. It's pretty good in terms of the examples and the complexities. I think if you want to become a decent questioner, then you should read Ben's books, so Ben's Goldachre's books, Bad Pharma and Bad Science, because those problems are basically entirely replicated in the software world.
Absolutely.
And then if you are more techie and you want to get into the depths, there are 3 books. One is an introduction to statistical learning with applications in R, FAB for understanding linear regression into machine learning, the algorithm design manual, big old textbook, and then the sort of Bible of all of this stuff is Russell and Norvig's AI, a Modern Approach. So those are my book recommendations.
Awesome. And last question, do you have any advice for students?
Students of medicine, life?
Students generally, yeah. All students.
All students.
Well, people early on in their careers.
Pay attention to what is happening. So there's a fairly good chance that at the moment we're in a slightly weird environment where, unless you're in a research-focused university, your curriculum is, I hate to say this, probably out of date. So most of this stuff is happening, quote unquote, in the real world. And so some of the onus has got to be on you to paying attention. And I think social media gets a really bad rep for a lot of things, but I actually think for staying on top of the cutting edge of research and the cutting edge of the developments in tech, social media is an absolute blessing. And you will find amazing content and good quality. You'll also find a lot of crap, but you will find really good stuff on social media. So pay attention. And then the other thing I would say, I was saying this to a bunch of medical students the other day, is put yourself in the room, put yourself in the conversation. I think there's a real, I don't know whether it's an imposter syndrome thing where people think, oh, I don't yet know how to make a machine learning model, therefore I have no right to be asking questions or being involved in these conversations. And I think that's really wrong. And I think that's where one of the reasons why we're sort of going down a slightly risky path, because not enough voices are involved in that conversation. Clinicians have amazing things to bring to the fore. Students of all types of things, humanities students, social scientist students, be in the room, ask awkward questions, because there's a pretty good chance that you will ask a question to a machine learning developer who will have never thought to ask that question of themselves or their company. And you could have a real impact just by making yourself heard. So sort of, I suppose, don't wait until you feel like your opinion is valid. Start having an opinion now.
Fantastic! What a great way to end the episode. Jess, thank you so much. That's such an interesting chat. Really enjoyed that. So much complexity to all of the where this healthcare data goes that you just never really get told when just sort of on the shop floor. But really great to hear about the work you guys are doing and spearheading hopefully a better future for all of our healthcare data and just all our lives generally.
Thanks for having me.
A massive thanks to Jess Morley for taking her time. You can find links to her work in the description. Thanks for listening, and catch you next time.